The hospitals like things just the way they are. It gives them almost, complete immunity for any peer review, good faith or bad faith, that they conduct against a physician, and they like things that way. So the solution that I've come up with, and I've talked about in a number of talks I've presented, is I think that the physicians themselves need to stand up for ethical conduct.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. So this is a follow-up of the previous episode where we had Drs. Kaki and Huntoon and, Deb Gordon on the show. It was a medico-legal episode, and this is a follow-up to that episode. And, I have with me Dr. Huntoon again for this episode. And, for those of you who do not know Dr. Huntoon from the previous episode, he's a former president of the Association of American Physicians and Surgeons. It's the only national organization which is doing a substantial amount of work actually to fight sham peer review. And we're going to do a deep dive on some of the technical aspects of the peer review process and of sham peer reviews that have afflicted several physicians and surgeons nationally. And I wanted to take this opportunity to have Dr. Huntoon back on the show to ask him some of the technical terms around this process, because, as we uncovered during our previous episode, so many of us are completely unfamiliar with the technicalities of the processes and the procedures and our rights. And it's extremely important to be aware of our rights and to be aware of the processes so that we can make informed decisions and informed actions. So with that introduction, I should also say Dr. Huntoon remains the editor-in-chief of the Journal of American Physicians and Surgeons. And if you've not followed that journal, please do. You'll find incredible literature and articles written by Dr. Huntoon himself on different aspects that we're going to talk about in the show today. So with that introduction, Dr. Huntoon, welcome back on the show, and thank you so much for doing this for us.
Well, thank you for having me. It's a pleasure to try and help educate physicians about this important topic.
Absolutely. So I'm just going to jump right in because, we have some of these technicalities to cover. So I want to dive right in. My first question is, how can a sham peer review, be performed on competent clinicians? I mean, is that even an occurrence? And, that's the first question that comes to mind when, we sort of scratch the surface of this phenomenon, for lack of a better word, in our last episode.
So just a couple of preliminary things so everybody's on the same page. What we're talking about today is sham peer review, and that's peer review that's done in bad faith. And I'm not proposing that all peer review is bad faith peer review. Peer review done in good faith, we support. And good faith peer review should be collegial, educational, fair, done for the purpose of improving quality care and protecting patients. And it should incorporate substantive due process for the accused physician. So having said that, I want to provide you with the published definition of sham peer review, which is an adverse action taken in bad faith by a professional review body for some purpose other than the furtherance of quality health care, and that is disguised to look like legitimate peer review. So it's abuse of the peer review process. And you ask, well, can sham peer review be performed on competent clinical physicians? And the answer is yes. Sham peer review has ruined the careers of many competent physicians. And the reason that sham peer review, has been used effectively by hospitals that use it is because of the very strong immunity provided to hospitals and peer reviewers under the Healthcare Quality Improvement Act of 1986, which grants nearly absolute immunity to peer reviewers and hospitals.
So, tell us more about the Healthcare Quality Improvement Act of 1986 and what led the legislators to pass an act like the Healthcare Quality Improvement Act, which again, like you said early on, as a preamble to this question, we completely support good faith peer review, and good faith peer review is crucial, is important, is imminent, um, uh, for patient safety and for quality healthcare. Um, but to then abuse the system, so to say, or to abuse this legislation to come up with something like bad faith peer review. How did the legislators not think of this when they were coming up with this law?
Well, that's a very excellent question. The history of the Healthcare Quality Improvement Act, which was passed in 1986, has to do with a case called Patrick v. Burgett. And this was a case out of Astoria, Oregon, and it was a sham peer review, and it was basically a proven case of sham peer review. And the doctor sued for antitrust violation. That's Dr. Patrick. And it went all the way to the U.S. Supreme Court. And I will tell you that AAPS, the Association of American Physicians and Surgeons, filed an amicus brief supporting Dr. Patrick at the U.S. Supreme Court, while another major medical association filed an amicus brief on the side of those who performed the sham peer review. To make a long story short, Dr. Patrick prevailed and got treble damages, as you can get under antitrust violations. And so that was the case that led to the passage of HCQA. The AMA got all upset and said this is going to chill peer review if doctors can sue hospitals that do this sort of thing. But again, remember, it was a sham peer review that they did on Dr. Patrick. So legislators looked at this, and the law that they came up with and was passed, Healthcare Quality Improvement Act, some refer to this as HCQA, basically, and hold on to your seats, it considers accused physicians to be guilty of the charges unless and until they can prove their innocence by a preponderance of the evidence. And that sort of turns, American justice on its head, where we're used to, hearing you're innocent until proven guilty. If you're an accused physician, you are guilty unless you can prove your innocence, and it's your burden to prove the innocence. And that's the tragic history of HCQA.
Wow, it certainly is tragic, because it's like you said, it's innocent until proven guilty otherwise, and it's turned on its head, as you appropriately mentioned. So, let me ask you this: what are the steps that a physician can take? Because the physician who is subjected to sham peer review knows that that particular physician has been subjected to sham peer review. So what are the steps that that particular physician can take to mitigate the rapidity of the train once it has left the station?
Yes, another good question. And I've written an article on this called Sham Peer Review, Disaster Preparedness and Defense. And by the way, all of these articles are available to download free of charge, no usernames or passwords or anything like this. All you have to do is go to the AAPS website, which is aapsonline.org, and simply search my name, Lawrence Huntoon, LAWRENCE and it will take you directly to all the articles that have been published on this, as well as video presentations. But to answer your question, the best approach is to try and have a disaster preparedness plan ready ahead of time. But most physicians don't do that. And the reason is most physicians consider themselves to be competent, good physicians and think that this will never happen to them because they are competent, good physicians. And that's a naive view and certainly not true. But once you are attacked, there are things you need to do, fairly quickly. And in the article, I go through these things, step by step basis. But obviously, one of the first things you need to do is get a knowledgeable attorney on board as quickly as possible so that your rights can be protected.
Excellent. And, I would recommend the listeners of this show to actually download the article. It's very informative, and it sort of goes over the step-by-step process of what one can do to safeguard one's own entity and identity, and then it talks about rights, and then goes on to some of the offensive measures that one can take, if need be. And both Dr. Huntoon and myself pray that none of us are ever in that situation or scenario. Which I think is now a good segue. We're talking about offense, and we're talking about some of the processes which surround this process. Some technical terms, Dr. Huntoon, and I think it'll be helpful for the listenership to understand more from you about the meaning of these terms, because again, a lot of the physicians aren't even aware that these terminologies exist, that these processes exist, or that these, for lack of a better word, tactics, on part of the hospitals exist. And I'm going to, explain myself here in a little bit. But my first question is about an investigation. When a physician is under investigation, what does that mean?
Well, an investigation is typically defined in your medical staff bylaws. Interestingly, the term investigation is not defined specifically in the National Practitioner Data Bank Guidebook. And that has caused some issues in the past. But an investigation is basically a formal look into the physician's practice. And again, it is covered and is under the medical staff bylaws as to how that occurs. The other thing I want to just add about investigations is, according to the National Practitioner Data Bank Guidebook, a hospital does not have to inform the physician when an investigation is underway. So in some cases, a hospital has sent out records to an external reviewer and they don't even tell the physician. The issue then can happen where if the physician perceives that something bad is going on, he decides to resign from the hospital and get out of there. If you resign while there's an open investigation, you will be reported to the National Practitioner Data Bank, and your career will either be ruined or over. They don't have to tell you. They can do a secret investigation. You know nothing about it, but if you resign while that investigation's ongoing, it can ruin or end your career.
Mm-hmm. I mean, it's kind of saddening to hear that, that physicians really have nothing to safeguard themselves against, this menace, and just the unopposed power of hospitals and institutions is. And I'm again, we're not for the listenership or for the audience, we're not questioning the sanctity of a good peer review. This is a bad faith peer review. Then if someone decides to level up and just do a formal investigation secretively, is there anything that physicians can do about this at all? I mean, is there a formal appeals process? Is there something? Is there anything?
Well, there is no appeal to an investigation. An investigation is just that. It's looking into the facts and the evidence and whether or not a physician provided safe care and care within the standard of care. And there is no appeal to that. It's and investigations can arise in various different ways.
Which brings me to my next question of, what is, so two terms here. One is Fppe, and then the other one is Oppe. If you can go over those terms for us and for the listenership, I think that'll be very helpful.
Sure. These were terms brought to us by the Joint Commission in 2007. And by the way, one of the founders of the Joint Commission is the American Hospital Association. So the hospitals kind of like things, that favor the hospital and disfavor the physician. But these were two terms, OPPE and FPPE, which the Joint Commission introduced in 2007 as tools to help hospitals make privileging decisions. So just briefly, the OPPP is an ongoing professional practice evaluation, and it's a screening tool to evaluate, basically all practitioners in the hospital. So the key thing to note there is it's not a review that's focused on an individual physician. So, for example, in your hospital, they likely have procedures for pulling certain charts, deaths within 24 hours of admission, unexpected deaths, unexpected complications, and whatever. And that is a review to which all physicians at the hospital are subject to. The FPPE is a focused professional practice evaluation. And the thing to note there is it is focused on individual physicians. And it's something that can arise if something is discovered in the OPPE process, but it sometimes arises from simply complaints that someone may have filed against the physician. And I think the key thing to recognize for your listeners is that an FPPE often functions like a star chamber proceeding. If you're not familiar with that term, star chamber, this was an English court at the palace in late 15th century and continued into the mid 17th century. And it was a room with stars on the ceiling, which is why it's called star chamber, where, the elite sat in a room, closed doors, and did not get the accused person in front of them to question or tell his side of the story. And they decided behind closed doors what punishment they were going to inflict on the person who came before them. So that's often how these FPPEs are initiated. And I will tell you that there is no appeal to an FPPE. They can force you to do certain things under the FPPE, and there is no appeal.
And then, I should ask you this. So, anytime anyone is under FPPE, that is different from being under an investigation, right?
Well, the FPPE is a focused professional practice of evaluation. So it's certainly a lot of overlap there between that and an investigation. And in fact, it may have been an investigation that sort of morphed into the FPPE.
Mm-hmm. Is FPPE, so anytime anyone is under FPPE, is that reportable to the National Practitioner Data Bank?
Great question. Not all FPPEs are reportable. In fact, most are not. So an FPPE, what are some examples? They may want the physician to obtain certain coursework, pass certain coursework. They may decide that they need to monitor the physician's procedures for a period of time, 3 or 6 months. And those FPPEs are not reportable to the data bank. However, if an FPPE involves a proctorship, what's a proctorship? That means another physician who's qualified needs to be in the same room with you when you're performing surgery or a procedure, for instance, and they need to give their approval for the procedure to proceed. That constitutes a restriction on the physician's privileges. And again, restrictions on the physician's privileges can certainly be reportable to the data bank.
And so, no, this is, an excellent point and great discriminatory point, I would say, between, FPPE, which may or may not be reportable to the National Practitioner Data Bank. I did, you did mention something else in the previous episode, and that was abeyance. And I wanted to sort of ask you this question and understand that term more from you. Because I'm not familiar as to I understand that term at all. It's a new term for me, as I'm sure it will be for many who are on the show listening. So what is an abeyance, and is it a tactic or is it a tool that is utilized by hospitals and healthcare systems? If you can just share that with us, that'll be very helpful for the audience.
Yes, well, hospitals introduced the concept of voluntary abeyance years ago, and they have been using it as an alternative to a summary suspension ever since. And so what happens is, in a voluntary abeyance, the physician is asked to sign an agreement whereby he agrees not to practice in the hospital or not to perform a certain procedure or surgery until an investigation can be completed. The thing to know about a voluntary abeyance is it is almost never voluntary because it is always presented with an or else. The physician is typically told that if he does not agree to the voluntary abeyance, a summary suspension will immediately be imposed. And so it's done under threat and coercion. And in some cases that I've seen recently, the physician meets with these hospital leaders and is given this option of a voluntary abeyance, and he is told he must decide on the spot whether or not to sign the voluntary agreement during this meeting, and he will not be allowed to consult with his attorney prior to making his decision. That, to me, is evidence of bad faith in conducting the peer review, when you're not allowed to even consult with your attorney before signing an important agreement like this. And the data bank, since January of 2010 has made it clear that a voluntary abeyance carries the same significance as a summary suspension. So once a voluntary abeyance is in place for more than 30 days, it's reportable to the National Practitioner Data Bank and can ruin or end your career. And a lot of hospitals tell physicians, oh, look, it's only voluntary. It won't hurt you. It won't be reportable to the data bank. They will outright lie to the physician to more or less coerce the physician to sign the voluntary abeyance. And when the 30-day mark hits, the doctor finds out, it's reported to the data bank.
I mean, in terms of, this is all great information, and it begs the question as to, it's an obvious question as to how, physicians should get educated on hospital bylaws and peer review processes. And you briefly touched upon this during our previous episode, but here's what I'm going to ask you is, my first question is, why should physicians get educated in these processes? And, after we've discussed all these fine points, it shouldn't be hard to convince any physician to get educated on these processes. But the bigger question is, how should physicians get educated on hospital bylaws and peer review processes?
Yeah. So the first thing I want to remind physicians that are listening is, I'm not an attorney. I don't give legal advice or legal opinions, but it's very important for physicians to read their medical staff bylaws, particularly the sections involving corrective action and summary suspension. The medical staff bylaws are what govern things in the hospital, and that is where your due process rights are set out in the hospital. And so it's important to read them. I know a lot of physicians don't want to look at things like that. It's picky medical legal stuff. I don't want to deal with that. But you don't want to wait until it's hit you personally and then try and play catch up and read the medical staff bylaws and see what your rights are. You really should look at those and have an idea of what due process rights you're entitled to under the bylaws. And I will say that the medical staff bylaws in most states constitute a contract between the hospital board of directors and physicians on medical staffs. In some states, it's still not considered a contract, which can be problematic because then some hospitals argue, well, too bad, we violated the bylaws, but since it's not a contract, we don't have to follow them.
Yeah, and then, my second question in that two-question segment was, how should physicians get educated on peer review processes? I mean, this obviously is an effort on the part of Parallax and yourself and AAPS and even the previous episode with Dr. Kaki to sort of motivate physicians to get educated on, the concept of peer review process and, the due processes which are in place so that they are in familiar territory. But, what are some of the other resources other than AAPS, obviously, that physicians may use to get educated on these concepts?
Well, it's pretty much AAPS at this point. The AMA put out a Board of Trustees report back in 2008 where they essentially said sham peer review doesn't exist. And they were about 4 years later, they sort of announced quietly at an interim meeting in Chicago that, well, we will start maybe providing information to physicians who've been affected by sham peer review. Well, if it doesn't exist, why would you be providing information to physicians who've been affected by sham peer review? And they don't have nearly the information and knowledge and expertise that AAPS has in this area. And again, the best way to educate yourself, I've written numerous articles on this. A lot of them are short, maybe 5 or 6 pages at most. And they're, again, downloadable free of charge from the AAPS website. And that's the best way, I think. And there's videos on there, too. If you don't want to read the articles, there's videos that cover some of the same topics. And one of them is tactics characteristic of sham peer review. I've done a number of articles on that and updated them. Physicians need to recognize the tactics that are being used against them that are characteristic of sham peer review. And this is the best source to go through and learn about those various tactics.
Yeah, I mean, you're vastly experienced. I mean, you're a national, expert on this topic. Would you be kind to share some of the tactics that you've written about and you've seen and you've probably testified against for the audience?
Sure. And there's a whole bunch of them. That was the topic of an entire talk that I gave, which is also posted on the AAPS website. But certainly one of the common ones is the ambush tactic and secret investigations. So the ambush tactic, frequently what happens is the accused physician is invited to what's called an informal, friendly meeting with the chief of staff and maybe the hospital administration. And I will tell you that all the people, except for the accused physician, who will be at that meeting, know exactly what it's about, all the details. They typically do not share the details about what the meeting is about with the accused physician. They tell the physician, well, look, we will tell you more about it when we get in the meeting. Well, that's an ambush. The physician doesn't have time to prepare if they're looking at specific cases to prepare to discuss them. And so when the physician doesn't have time to prepare, he kind of fumbles around trying to remember the case or procedure, whatever it was. And fumbling around makes the physician look guilty. He's not defending himself very well. So that's the ambush tactic. Then there's the tactic of depriving the accused physician of charts, complaints, incident reports needed to defend himself. That's a pretty blatant violation of due process and fundamental fairness. The hospital just doesn't give you the specific charts you need to prepare your defense. Then the medical staff bylaws in a lot of hospitals sort of parallel HCQA in that they state in the bylaws that basically the physician is presumed guilty prior to the peer review hearing, and the burden is placed on the physician to prove his innocence. There's the numerator without denominator tactic, which is something that is used for physicians who perform surgery or procedures. They will cite the numerator. Oh, look, he's had 5 complications. But you sort of got to know the denominator, don't you, to be able to evaluate, is this out of the norm or within acceptable range? So if the doctor performs 10 cases and 5 of them he has complications, that's a 50% complication rate. But what if he performs 5,000 of those procedures and has 5 complications? Very different implication there, isn't it? But so they just cite the numerator. Oh, look, he had 5 terrible complications. Then there's misrepresentation of the standard of care. Some hospitals will hire external experts, and the external experts will basically say, well, the surgeon or cardiologist didn't do things my way. My way is the best way, and so he's practicing below the standard of care. That's misrepresentation of the standard of care. We know that there are perfectly legitimate different ways to treat and approach certain patients and conditions that are perfectly legitimate, and just citing one side as this is the best and standard of care approach is not appropriate. And then we see false and trumped up charges. I'm increasingly seeing charges that are just completely false and fabricated, that are proven to be false and fabricated, yet the hospital goes forward with them. Then there's abuse of the disruptive physician label. That's a real common one. When they can't get the physician on some competency issue, they will often shift the prosecutorial theory to something more subjective, like disruptive physician. And there's a whole bunch more. I mean, there's like, I got about 30 of them listed. But again, you can go to those articles and see what each of them are.
Yeah, no, excellent, excellent answer, and thank you for going over some of these tactics, and again, for the listenership, if you are interested in this topic, we certainly hope that you're not afflicted by this menace. But if you're interested in this topic and want to learn more, or if you know of a colleague who's been afflicted and want to direct him or her, the right way, then certainly direct them to the AAPS website and some of the terrific articles that Dr. Huntoon has written himself, which are, again, very easy to read. They are concise and they are very well detailed and very well, the explanations are terrific, and you'll sort of understand the lay of the land and the processes that are in place, so that you can, just completely arm yourself well when you are trying to fight this occurrence, in your professional life. Dr. Huntoon, which does bring me to the next question, and that is, and maybe I'll sort of end the podcast by asking you a little bit more about AAPS and how the listenership at Parallax can get involved. But before that, my first question, my next question actually is, how can we usher in change and change the landscape so that our peers, our colleagues, don't get afflicted by this? We sort of broached this discussion in the previous episode with Dr. Kaki and with Deb Gordon, that this has led to burnout, quiet quitting, the Great Resignation, physician suicide, what have you. How can we usher in change, and how can we change this landscape for the better?
I've thought a lot about this over the years, and sometimes physicians think, oh, all we need to do is lobby our legislators in Congress and show them the inherent violations of due process and fundamental fairness built into the HCWA law. Surely they'll see that and change it. The reality is, lobbying Congress to, repeal HCWA or remedy it is not going to be effective. The reason being is the Hospital Association is a very, very powerful association that donates a lot of money to Congress. Physicians, on the other hand, generally don't donate that much money to Congress representatives. And the hospitals like things just the way they are. It gives them almost, complete immunity for any peer review, good faith or bad faith, that they conduct against a physician. And they like things that way. So the solution that I've come up with, and I've talked about in a number of talks I've presented, is I think that the physicians themselves need to stand up for ethical conduct. It is unethical to perform a bad faith peer review on a colleague. And the Amish sort of have a solution to this, which may be a good solution. If people in the Amish community don't abide by the rules of the community, they're shunned. And I think that the same type of thing should apply in the physician community. We ought not deal with physicians who participated in sham peer review. It's an unethical act that they've committed, and you just ought to have no dealings with them.
Yeah, are we there yet? Is the next question. It's the next it's the next intuitive, obvious question. Are we there yet?
Well, we're not there yet. And again, you have to realize vast majority of physicians don't really even know about sham peer review, or if they know about it, they think it's never going to affect me. I mean, I've published hundreds of articles. I'm a good physician. I'm at the top of my specialty. This would never happen to me, but it does. So there's so many physicians out there that think that they don't want to get involved in anything having to do with sham peer review because it's not going to personally affect them, or they view it as not ever going to personally affect them. And so until we overcome that with education and telling some of these really horrible stories, I don't think that will change quickly.
And then Dr. Huntoon, just final remarks, maybe the final question as we end this podcast. And, thanks again for your depth of knowledge and for your mission and for your path that you've taken in your life to help colleagues and physicians and to become the national expert that you've become, and to so strongly be a voice for AAPS, to represent AAPS, and to write all these incredibly informative articles, which are so helpful for anyone who is interested in the topic, who unfortunately has been afflicted by the process and wants to usher in change. I truly thank you for your service to your colleagues. You're may the force be with you, and just innumerable blessings your way. But my final question to you is, if you can tell the listenership more about AAPS and its mission, and first of all, why should they get involved, and then how should they get involved?
Well, I think a reason to get involved in AAPS is you will help support the work that we're doing. And I should mention that some of the free membership benefits available to our members are two important ones. Number one, the AAPS free limited legal consultation service, which is a consultation with the nation's top attorney in sham peer review matters. And the other thing is members get free access to the AAPS sham peer review hotline, where they can receive, important information. I run the hotline on a pro bono basis as a membership benefit. So the AAPS, which is the Association of American Physicians and Surgeons, was established in 1943 with the main mission to support the patient-doctor relationship. And that's it. Our motto is Omnia Pro Agrado, which in Latin means everything for the patient. So again, if you want to get involved in supporting this important work that we do and have access to things like the AAPS free limited legal consultation service, the AAPS sham peer review hotline, you can go to the AAPS website, aapsonline.org, and look up some of these articles and join and support the work we do.
Excellent. Thanks again, Dr. Huntoon, for your time, and just incredible information. Any closing remarks for the listenership, for the show, for Parallax?
Other than I think education is key. The more you know, the better off you are, and that applies to a lot of things in medicine. It applies to peer review and peer review procedures as well. And thank you for the opportunity to help provide this information.
Oh no, absolutely, my pleasure. Thanks again, for joining us, and we'll be back with another guest in the next episode of Parallax. If you do listen to this episode, and if you have feedback, do share it with us. We read feedback very carefully. Do rate us and review us on various podcast platforms, including Apple Podcasts, SoundCloud, and Spotify, among others. Google Play certainly, or even Audible now. And until next Monday, everyone, thanks again for listening, and take care.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/parallax. Thanks for listening.